All right. Good morning, folks, and welcome to Friday Chalk Talk. Thank you guys all for being here with us today for our discussion on buprenorphine as well as microdosing. Today, I have the pleasure of introducing our two guest speakers, who are also the co-authors of a recent publication on buprenorphine and microdosing in the Journal of Palliative Medicine. First, we have Dr. Kyle Quirk. Kyle is a palliative medicine clinical pharmacy specialist. He works at the Ohio State University James Center Hospital. He completed his pain and palliative care pharmacy residency at the University of Michigan, and his professional interests include pain, symptom management, drug policy, and buprenorphine. Welcome, Kyle.
Thank you.
Yeah. And second, we've got Dr. Max Stevenson. Max is also a palliative medicine clinical pharmacy specialist. He works at MedStar Health Washington Hospital Center in Washington, D.C. He completed both his master's in bioethics as well as a pain and palliative care pharmacy residency at the Ohio State University. And Max shares similar interests in palliative care and bioethics, pain, and harm reduction practices for patients struggling with substance abuse. So welcome, Max.
Thanks for having me.
Absolutely. Our format for today will be two parts. Kyle, Max, and I have agreed to a handful of questions to discuss, and we'll leave a few minutes at the end for some questions from the audience. And so that we will jump right in. I think the way that we'll start is I'm going to share a hypothetical case of a John Doe. And this is something we're all going to be able to identify with. And we won't discuss it initially, but we'll circle back to it as we think about the questions. So John Doe is a patient who has really significant cancer pain, but still has a prognosis that may be many months, perhaps even years. So we all know that we have a long journey ahead together. And over time, his morphine equivalents have really escalated into the hundreds. Rising concerns are occurring for opiate use disorder. He struggles to function at home, spends more and more of his time in emergency rooms. And he has these frequent admissions for pain that are clearly much more complex than just physical pain. And this has really led to medical teams feeling moral distress, and you are being consulted to see him either on the inpatient or outpatient side. So Kyle and Max, for our first question, I think we start big picture. Can I ask you guys to touch base on really what you consider to be the most significant benefits, drawbacks, and perhaps myths around this drug, buprenorphine?
Sure. So when I think of benefits, I think of the patients, the sort of patient buckets where, this kind of patient is in front of me and I'm thinking buprenorphine right off the bat. And the two big ones, at least here, are the one you sort of already touched on, patients with opioid use disorder or, something in that arena. And, is buprenorphine a safer opioid for those patients? Or do we want them to be on buprenorphine to manage their opioid use disorder as well? And then the other big group of patients are the patients who are just not tolerating other opioids super well. So we think they have pain that would benefit from opioids. But it's your classic little old lady who's taken 2.5 of oxycodone and is out of her mind, or just sensitive to opioids. Sometimes it's patients who are hesitant to use opioids, or patients who aren't tolerating them, or patients who maybe aren't reporting that they're not tolerating them well, but we think for some reason they're not. So like delirious patients as well. And kind of related to that are its benefits in organ dysfunction. So we have a lot of patients with renal or hepatic dysfunction where we're thinking of using buprenorphine for them. And as far as tolerability, we can talk more about that, but some of the cognitive side effects of other opioids, we find that those patients can do really well on the inpatient side with low doses of intravenous buprenorphine or just slapping a patch on them. So those are the two big buckets of patients that I think of for using buprenorphine. And I don't know if Max wants to jump in more with benefits he sees.
Yeah, those are the main ones I think of as well, and also people who have maybe a tenuous respiratory status where we want to kind of lean on the safety profile of buprenorphine as from the respiratory status as well. So just like Kyle was saying, it's safe in renal dysfunction, just about as safe as what you would imagine, like other opioids that go through hepatic metabolism in hepatic dysfunction. But as far as some drawbacks that I was thinking about, one that comes up a lot is the stigma about buprenorphine and naloxone products. So thinking about Suboxone. So I think it's really similar to what we would encounter when starting, say, someone on methadone for pain, and the only experience this patient has with methadone is hearing about it in the news or hearing about, say, someone going to using methadone for opioid use disorder. So I think we have that as a drawback, or kind of something we have to address with patients in the beginning. Another drawback that I've come across is cost and coverage through insurance companies. So a lot of times there's some pushback with like needing prior authorizations to use buprenorphine, especially sublingual buprenorphine for pain, as well as even if you do get the prior authorization, there's sometimes a lack of familiarity with even like outpatient pharmacists, just needing some education on using buprenorphine for pain and its benefits and burdens for using it for those indications, even outside of opioid use disorder.
Okay. Yeah, and another big drawback I think of, and again, this is thinking of patients patients who you would use buprenorphine for versus patients where you might not, is a big decision point for me when it's treating a patient is how much time do we think they have left in their disease course. And so some of the benefits of buprenorphine have to do with its safety and efficacy over time compared to full agonists, versus one of the drawbacks being, especially close to the end of life, it's not necessarily medication that can be titrated very quickly. At high doses, you may hit a point where escalating doses further doesn't lead to significantly more analgesia. So that's sort of a decision point for me to a patient with, years left would be a better candidate. A patient with days to weeks left would be not as good of a candidate.
How about the myth, maybe not myth, maybe it is or isn't, about maybe it's a fear for inpatient that are here with pain crisis. If they're on buprenorphine, how am I going to be able to treat their pain crisis? How do you guys feel about that?
Yeah, that's a one that comes up a lot, I'm sure. So I think some of that is a legitimate concern and some of that is myth. So when it comes to the myth part of it, there's a concern that any patient on buprenorphine, opioids, full agonists added to it will be ineffective because the buprenorphine will block their effect. And I think importantly, it's important to state that is strictly false, particularly patients on lower doses of buprenorphine. So patients on transdermal buprenorphine or Butrans in the United States, which only goes up to 20 micrograms per hour, that's in the grand scheme of things, such a low amount of buprenorphine that's not going to significantly affect other opioids that are added to it. There are so many opioid receptors that are left open, even with a patient on like 20 micrograms per hour of Butrans, that an oxycodone or a hydrocodone, anything you want to add, we don't have to worry about that blocking. And then when we get to moderate doses, there's decent evidence that even at moderate doses of buprenorphine, that adding full agonists can still be effective. So there's a study that's over 10 years old now from Mercadante, where he had patients on transdermal buprenorphine up to 70 micrograms per hour, which is available in Europe. And when we think about what that's the equivalent to, if we're thinking about the bioavailability of sublingual buprenorphine, that's 6-8 milligrams of sublingual buprenorphine per day. So we're getting into decent doses of buprenorphine there. And, that study with 20 something patients showed that you can treat their acute pain by giving, what you think is roughly 20% of their long acting dose. Now, where we start to get concerned is higher doses of buprenorphine that, a lot of patients with opioid use disorder are on 16, 24 milligrams per day.
Mm.
And, there's studies that have been done with radio-labeled sufentanil, I think, that suggest that patients on, 24 milligrams a day of sublingual buprenorphine, that is binding, 90% plus of their opioid receptors in their brain. And so for those patients, I think it really comes down to, you mentioned a pain crisis. So for those patients with severe acute pain, we're definitely thinking about their buprenorphine. At least here, we're not stopping it, but you will see protocols more and more being published where for a lot of these patients, they recommend reducing the dose. I have yet to see anything rigorous studying, continuing their Suboxone at the same dose versus decreasing it to 12 or 16 milligrams to try to give those full agonists a fighting chance. But, that is something that can be done to try to address the potential blocking effects. And the other thing I try to tell people too is, 16 milligrams, 24 milligrams of Suboxone is a lot of opioid. And it's really hard to equate that to oral morphine equivalents. But it's obviously, it's clear that it's in the hundreds. And so, if you have a patient walking in off the street on 600 milligrams of oxycodone a day, their pain crisis is not going to be the easiest pain to manage. So, we're trying to be thoughtful about them, use all the non-opioids that the patient can have to try to take a multimodal approach to effectively manage pain. And, there are a couple studies out now in the acute pain setting that even show that patients who have their sublingual buprenorphine stopped end up using higher doses of opioids because that's an opioid that is providing analgesia that we're stopping for these patients. And then, of course, the big risk being, the number of patients who don't have it restarted before they leave the hospital. And so, for us, the risk of, stopping this patient's life-saving medication for their opioid use disorder and potentially not restarting it versus managing their pain with full agonists and non-opioids, we tend to just continue them. And, it's not a walk in the park always, like I said, but it can be done.
Yeah, I have a lot of the same points that Kyle was saying, just realizing that the patient is on those higher doses of buprenorphine sublingual, just realizing that these patients really do have a high opioid tolerance and using what we're used to, or say, these lower doses of full agonist opioids probably aren't going to cut it. A little thing that I like to sort of rely on too is just looking at the binding affinities of other opioid agonists that we use for breakthrough pain. So knowing that buprenorphine has such a high binding affinity and a long dissociation constant from the new opioid receptors, I also like to use another full agonist opioid for breakthrough pain that also has a high binding affinity. So namely, I'm thinking hydromorphone. And then if someone can't use hydromorphone for any reason, I'll think of fentanyl or morphine. So those are my preferred ones, particularly hydromorphone. Looking at like binding affinities for oxycodone, it's much, much, much lower. So I think you'll have a lot harder of a time competing for those mu opioid receptor sites. And just how Kyle was saying too about there's not great evidence on whether or not to continue patients at higher doses or titrate down to say 12 milligrams of sublingual buprenorphine a day to better manage these acute pain crises with other full agonist opioids. But yeah, a lot of the studies coming around, especially perioperative use of buprenorphine, like what do you do in those situations? Do you continue? Do you stop? Do you go down to a lower dose? Just as Kyle was saying, all the studies are really showing that if you don't continue the buprenorphine, patients are going to use higher levels of OMEs or higher opioid equivalents in that perioperative setting. And actually, just serendipitously, a couple of weeks ago, I had a patient who came in on Sublocade, which made it a little bit more challenging. So this is the long-acting injectable form of buprenorphine used for substance or opioid use disorder. So this patient I'm thinking of was on 300 milligrams of Sublocade a month. So that's roughly about 18 to 24 milligrams of sublingual buprenorphine a day, just roughly speaking. So he came in with an acute pain crisis due to an infection. And what we found was we could successfully treat his pain using both like a multimodal approach. So thinking about NSAIDs and other gabapentinoids, but also using oral Dilaudid for breakthrough doses around that 6 to 8 milligrams of oral Dilaudid actually did help control his pain, even with knowing that this patient is on a long-acting injectable form of buprenorphine.
Wonderful. All right. So let's say our patient John Doe, we all agree that we're going to transition him to buprenorphine. Can you guys take us through the process, sort of step by step of microdosing, and perhaps touch on why microdosing is just so well tolerated?
Do you want to start this one, Max?
Sure. Yeah. So step-by-step process, it's different. There's so many different methods out there in the literature using either IV buprenorphine, sublingual, buccal, transdermal patches. But in general, the thought is to start with very low doses of buprenorphine. So thinking like less than a 20 microgram patch, which is all that's available in the US, less than 0.15 milligrams of IV buprenorphine, less than like half a milligram of sublingual buprenorphine, or less than like 300 micrograms of the buccal buprenorphine, and slowly introducing buprenorphine through those methods by giving repeated doses while continuing or tapering off the full agonist. We can get into that a little discussion later, but in general, it's continuing a full agonist opioid while slowly introducing buprenorphine until the point where we're at a, say, therapeutic dose of buprenorphine. When you get to that point, you can safely stop the full agonist opioid. So it's really relying on those special receptor binding kinetics, namely the high binding affinity and the low dissociation from the opioid receptors. So in general, it's just, again, starting with low doses of buprenorphine, continuing the full agonist, and slowly titrating up on buprenorphine until you're at that point where you can discontinue the full agonist.
Yeah, the big concern, of course, is that if you have a patient who's highly tolerant to opioids and you give them a big dose of buprenorphine, then we're worried about precipitating withdrawal. And so that's related to the dose of the level of tolerance or the dose of opioids that they're already on. So, patients, our patient on hundreds of OMEs is going to be at higher risk for precipitated withdrawal than someone who's taking hydrocodone 5 milligrams 3 times a day. And this is a dose of buprenorphine. So, the old fashioned way to start buprenorphine is stop the full agonists, wait a certain amount of time, depending on what full agonist that is, wait for mild withdrawal or increased pain, and give them, 2 milligrams or so of sublingual buprenorphine. So 2 milligrams of sublingual buprenorphine in a patient who's highly opioid tolerant, you run the risk of precipitating withdrawal. But with these very low doses, the risk is extremely minimal of precipitating withdrawal, just because, again, it gets down to how many receptors the buprenorphine is actually going to be kicking their full agonist off of. And so with slowly increasing it over time, it's just a gradual process that doesn't send the patient off the cliff or down the elevator shaft, or whatever analogy you want to use for the precipitating withdrawal. As far as how to do it, like Max said, I mean, there's dozens of articles now that have been published on this, and almost no two have been done the same way. We like to talk about the ones that were done in the old days. You might read about the Bernese method, and they would give a very small dose once on day 1, and then wait a full 24 hours and give maybe a slightly higher dose. And then we found that, and this is all, other than that, and a couple articles here or there, all of these articles are from the past 3 years. And so there was an article from 2019 where they said, you know what, it doesn't make sense to wait 24 hours after a dose of sublingual buprenorphine because of its time to peak effect and its half-life. So you can really give it, every 6 hours, every 4 hours, and get this process done a lot more quickly. So in general, when if the patients are on lower doses to start with, or if they're inpatient, we find that it can be done pretty quickly. And sometimes we find that, it has to be done quickly due to, discharge pressures, right? So, we're a consult service, so we'll be told, John Doe's leaving Friday and get them on buprenorphine. And so sometimes, we modify the plan based on that. But certainly, inpatient, we go a little bit faster. And as far as what product to use, that's going to be based on local formularies, whether you're inpatient or outpatient. So here at Ohio State, inpatients, we tend to use buccal buprenorphine, and we'll start at a low dose and increase it every day. On the outpatient side, due to cost or coverage issues, we'll use sublingual. Start a patient at a quarter of a 2 milligram Suboxone strip 2 or 3 times a day, slowly increase it. Have a pharmacist call him a few times between when we start it and his next clinic appointment, make adjustments there, assess for withdrawal, and we've had tons of success doing it inpatient and outpatient.
Wonderful. We're just about at 20 minutes now. Let me ask you just one more question, and then we'll open it up for some questions. Can you guys maybe share a success story, or maybe even a shortcoming, some things that we can learn from your personal experience, without, of course, being too detailed and being HIPAA respective for patients?
I think the drawback that I've seen is when the process is going too slow. When there's, like I was alluding to earlier, there's a discharge stipulation by the primary team, and we're acting as a consult service. We can't really hold up the discharge. So especially when I was first starting to do buprenorphine microdosing, and getting more comfortable with the process, I wanted to do a longer than probably necessary microdose induction over 3, 4, 5 days, where there's a lot of data coming out showing that with these rapid or ultra rapid inductions, patients can even tolerate a 24-hour or a couple of 2-3 days at most of an induction. So that was, I think, a drawback that I saw in reflection. But I think just seeing the multitude of reports also coming out showing about the high success rates of buprenorphine microdosing just speak to the how we can really help these patients out.
Yeah, the first patient I ever did a low dose or microdose induction in was during training, and I had actually given grand rounds on using buprenorphine for cancer pain. So one of the outpatient palliative doctors identified a patient that she thought would benefit from it, and this was a patient with chronic non-cancer pain on fentanyl and oral hydromorphone with just poorly controlled pain, poor functional status, frequent pain exacerbations that led to hospitalizations. And I had no idea what to do. So that's the first time I basically just, did a lit search and read every case report that there was on this process. And, like I said, called the patient a few times over the course of a week to get her through it. And she ended up, with much better pain control after the switch. So patient identification in those situations is definitely one of the hardest parts. But as far as the process goes, we find that with a little bit of practice, it's pretty uneventful usually.
Wonderful. Right. So we've got a question in the chat from Andy. She asks, how do you guys decide which patients may be better served with buprenorphine versus methadone? That's
a great question. So like I said earlier, one of the big patient buckets is, patients who are on very low doses of opioids, maybe having trouble tolerating opioids. Those patients, we might do low dose methadone in, but for a lot of them, we're doing low dose buprenorphine, like the transdermal products, and they do extremely well. And then all of the other things that go into deciding whether you think a patient would do well on a patch. So a lot of our patients like that it's one patch a week that they only have to change, every Sunday and get 24/7 pain relief. Usually where it gets tougher is these patients who are maybe on high doses of opioids with poor pain control, and do we think they would be better served from methadone or maybe switching to buprenorphine? Part of that comes down to, which patients do you see in your practice that you really think would benefit from methadone? And I don't think that buprenorphine necessarily replaces that. So, patients on high doses with terminal pain, with complex cancer pain with a neuropathic component, and a decent level of tolerance, we're still switching a lot of those patients to methadone, definitely. As far as which patients maybe to switch to buprenorphine, I think, again, it gets back to how long they have left in their disease course. So in my practice, we don't do a ton of chronic non-cancer pain management, but you do have your patients who get through treatment and are expected to live 5+ more years, or there's patients with cancer and they of course have non-cancer pain at the same time from their previous life that they had. And so those patients, I think, we're definitely thinking buprenorphine for them. And then when it comes to the patients with opioid use disorder, if we're going to be managing them, we found in our clinic that it's hard. It's the patients with opioid use disorder that we're managing have done better on buprenorphine than trying to treat their pain with methadone. So those patients, and again, this all comes down to severity of pain, severity of their opioid use disorder. Some of those patients were maybe be seen by a methadone clinic, and then we're seeing them in the palliative care clinic to do the other things for their pain. So sometimes that's giving them full agonists that that their methadone clinic is okay with, aware that they're getting, or prescribing all of their non-opioids.
Let's we have one more question here, and then we'll end for the day. Pooja asks, what about patients that are really, really struggling to be open to something like buprenorphine? Maybe they have had other opiates that have worked better in the past. They're pretty reluctant. How do you talk to these patients? How do you pitch buprenorphine to them to make them reconsider if you really think it's going to benefit them?
Yeah, I think getting patient buy-in is one of those first hurdles that you have to get over. So what I like to do is talk to the patient, see what their understanding of their current pain management is, and if there's a concern that they're not getting the full benefit from this full agonist, I think there can be a route of buy-in saying, look, we know that these full agonists these other opioids aren't working. I think it might be worth trying something else that could work. And then especially with the buprenorphine like microinduction, you get more buy-in saying you can continue the medications that you're on, but I think trying this other medication, this other opioid, buprenorphine, we might even be able to get better pain control, just seeing how the complexity of your pain or other patient-specific factors we can talk about. It might be a safer option for this patient. It might be more practical for this patient. So I think it really comes down to the shared decision-making and making sure that patients have the right information they need and getting that buy-in through a shared decision-making process. But usually the points I usually hit on are, it seems like these traditional opioids that we're using aren't helping your pain fully, and maybe we could try something a little bit different, and really focusing on the safety aspect as well.
Communication and relationship building,
Yeah.
core of palliative care. All right, Max, Kyle, thank you guys so much for joining us today. I'm sure there are lots more questions, but that's all the time we have with you. We appreciate it.
Thank you. Thanks for having us.
Yeah, it was great.
Absolutely. All right, have a great weekend, everybody.